Okay, great. So it's great to be here, and I wanted to follow up with a little bit more information on one of the outcomes that I think is really important along the lines of the neurocognitive effects, and that's educational attainment. And lead has been associated, besides the neurocognitive measures, has been associated with poor school performance as measured by end-of-year grade exams in reading and math, particularly at third grade, failure to graduate from high school. There's real concern with regards to this because kids who don't graduate from high school then are not going to go on to get jobs and to have productive lives. So it has a much bigger effect than a health effect alone. So what do we know about reading readiness? Again, another marker that we measure usually at kindergarten. About 25% of American children enter kindergarten not ready to learn to read. If children can't read by second grade, then they typically will have really severe problems and failure in school. So there are many, many programs geared to reading readiness at the kindergarten level for kids who still don't achieve benchmarks in kindergarten, first grade, and certainly in second grade for those that are still having difficulties. So the lack of readiness is very costly. It's much cheaper to intervene earlier rather than later. Just for example, the cost of preschool or kindergarten, $5,400. Repeating of one grade in Virginia, $8,100. And if we go to special education, $16,400. So big costs, big differences. Some of the studies that have been done, and you may know of these, this is also Bruce Lanphear's, this is using N. Haynes data, 1988 to 1994. You can see here the clear dose response from the lower blood lead levels, where you have the higher test scores, to the higher, which is over 3 micrograms per deciliter, relatively low, where you see the difference in the outcomes and very statistically significant. Mary Lynn Miranda and her colleagues at Duke studied black and white English-speaking children in North Carolina with 1 blood lead level, and they looked at third grade reading outcomes. And as you can see at the lower blood lead levels, and these are 2 models, one using average and a linear blood lead model, and the other using blood leads grouped around 2, 3, 4, 5, etc., micrograms per deciliter, and then 10 and above. And you can see this very sharp decline for the blood leads that are below 10. My own research looked in Providence, Rhode Island, looked at kindergarten reading readiness and lead, and found a very similar trend with blood leads of, with increasing blood leads, the decrease in readiness. And these are very statistically significant changes as well. So I want to talk a little bit in this section about who's affected, what the recommendations are when they're effective, how we can improve primary prevention, barriers and opportunities, and a little bit about next steps. So I want to thank a number of people. I've more in touch with the public health community, from Patrick Parsons, who chairs CDC's laboratory group that's been looking at the laboratory issues associated with these new recommendations, to the staff at MDE, who run all levels of the program, Peter Simon from the Rhode Island Department of Health, Kate Scott from Baltimore City Health Department, Jane Malone from the National Center for Healthy Housing, members of the Maryland Lead Commission, in particular Barbara Moore from Mount Washington Pediatrics, who's made me very well aware of some of the issues for providers and families, and Mary Jean Brown from the CDC. So just another look at this amazing decline in blood leads over time. And I want you to think about this group of children here, 1995, 1996. You can see from this table that we have 15% of children tested in those years who had blood leads over 10, 15%. Now, these children are now 17 years old. They should be graduating from high school. Many have started or will start having children, and they've had significant lead exposure. So even though we're tracking down here and we're really interested in what's going on here, these kids are with us. They're part of our population. They're in our schools. They're having children, and we're going to be bearing the burden of this exposure for a long time. So I want you just to think about that as we think about these new recommendations. So I think there are many groups affected, certainly public health, environmental health, housing, education agencies at all levels, primary care providers who will be in positions to see children and their parents when they come for health care, families who are impacted who have children with higher lead levels, and advocacy organizations that work on their behalf. So what is recommended? There are 13 points, basic points in the recommendations. The first is it eliminates a level of concern. Based on the research that Anna reviewed, you know now there's no safe level of lead, and this certainly is acknowledging that. The recommendation set up a reference value based on the 97.5 percentile of the population blood lead in the United States of children ages 1 through 5. Right now, that is 5 micrograms per deciliter. It could change. It could go up. It could go down. It's going to be reassessed every 4 years. And the reason for this is twofold: to identify children and to identify environments with lead hazards. So we're thinking here primary prevention. The third point is to develop and implement a national primary prevention strategy to ensure that no children live in or spend significant time in homes, buildings, or other environments exposed to lead hazards. Now, we're not going to get there tomorrow. We have lots of older housing in our stock, especially in cities like Baltimore. But we have a lot of progress to make. And I will point out that the push for primary prevention did not start with these recommendations. 2004, we had additional recommendations put out for primary prevention housing-based approach. And so the CDC, the state and local lead programs all over the country have been focused on primary prevention for many years. This is not a new idea, and there are many elements already in place across the country in most states and local jurisdictions, although they vary across the country. So on the clinician side, the recommendations talk about clinicians serving as a reliable source of information on lead hazards and taking a primary role in educating families. They talk about environmental assessments prior to blood lead screening. Why should we wait for a child to have a higher blood lead level? We should be finding out, are they at risk in their environment? And this can be done before the child even starts to walk. We have clinicians notifying families and monitoring health status of children with confirmed blood lead levels. The schedules for retesting, confirmation follow-up are all in the guidance. So it's pretty clearly laid out. I'm sure there'll be questions, and it'd be important to talk through how that's actually done, but there's a pretty good set of guidelines there in the new guidance. Now, for states that don't have mandatory reporting, we do in Maryland, and many, many states do. Clinicians are basically called to ensure reporting of blood leads at or above the reference value to local and state health and housing agencies, and then to collaborate to provide appropriate services. I think for many of the areas across the country, we have required reporting, so this will not change the role of clinicians. Our reporting here and across most of the country is based on laboratory reporting. Other recommendations are education on primary prevention in homes, in child-occupied facilities to eliminate hazards. And again, we're targeting families, providers, advocates, public officials. Further developing the primary prevention infrastructure. And this includes data sharing between health and housing, development and enforcement of preventive standards for housing, for rental and owner-occupied properties. I would add that in Maryland, about half of our new cases of children with blood leads of 10 and over are in owner-occupied properties. So this clearly is no longer a problem of rental housing alone. Identifying funding for lead hazard remediation, always an issue. and providing families with information so they can protect their children from home environmental hazards. And families are a very important part of this picture, and they will do what they can to protect their children within the homes that they live. Recommendations continue to work with elected officials, health, housing, code enforcement agencies to adopt policies that protect children from lead exposure, and adopting primary prevention strategies to reduce exposure in soil, dust, paint, and water before children are exposed. So we're emphasizing environmental assessment, and we're emphasizing remediation of hazards and protection of children. Action, not just measurement. With regards to the final recommendations, targeting of multifamily housing. If there are lead hazards found in any unit in a multifamily property, like an apartment or a duplex or a home with 3 or 4 units, then lead hazards found in one unit will trigger actions in the rest of the units unless those units have been tested and found to be free of hazards. This is very important in terms of trying to continue the prevention and not let go opportunities where other children are at risk and could be poisoned next year, the year after. We want to really take what we can and take action as quickly as we can. The guidelines encourage health outcomes research based on interventions that can maintain blood leads below the reference value. We don't have that kind of research done now, so we can't say, well, if I do X, then I'll have the effect of reducing the blood lead. We don't know that. So there will be the need for outcomes research. And then with regards to priorities of research, the CDC has established improving the use of screening data, developing the point-of-care analyzers, the handheld analyzers that I'll talk about in a little bit that could be used to promote further screening, and improving knowledge of epigenetic mechanisms of lead action. Now, overall, this is a major shift to primary prevention at all levels. Again, as Anna had talked to you earlier, no level can be thought to be safe, and these guidelines are clearly calling for action that's unacceptable to wait until children reach a specific blood lead to qualify for lead-safe housing, that is not where we see this going. We're also not going to further secondary prevention. We will be doing follow-up with individual children, but we want to focus on primary prevention and looking at population. So I'll try to explain that a little bit better. Now, when are they effective? The guidance was issued on January 4th of this year. In May, the CDC reviewed and issued a response that they concur in principle on all points, but had concerns about the ability to carry out some of these guidelines based on funding. I will point out that the CDC budget cuts eliminated funding for state and local CLIPs beginning in fiscal year 2013. We went from $29 million in fiscal year 2011, which then funded local programs in fiscal year 2012, which is what we're in right now. And in 2012, we dropped to $2 million, and that's the budget amount. It may change when the House finishes its markup, but the budget amount has been this year $2 million, which does not include money for state and local childhood lead poison prevention programs, or CLIPs. So despite many national efforts to restore funding and working with congressional delegations, senators, many of the state and local CLIPs are facing layoffs as of September 30th of this year, the end of the fiscal year. Nobody knows at this point if money will be found to keep people on board, to keep programs in place. And I believe CDC is intending to do a survey of that, but it's still unclear what will be done. And states will implement based on their data and their resources. And so I think we don't have a clear idea of all what will go on across the country. Now, just as we think about prevention, want to just step back and think about where children are exposed to lead, how they get exposed to lead from all these sources that Anna talked about. There are many, many sources that children are exposed to in their home. At levels of 5 to 9 micrograms per deciliter, the lead in housing and soil are important contributions, but many more factors can actually impact blood lead at this lower level. Housing is really important, has long been identified as the major culprit. Rental and owner-occupied, and houses built before 1950 are at highest risk, but homes in poor repair and homes undergoing repair, renovation, repainting with high exposures to dust are at very high risk. So there are new sources of lead exposure identified regularly. It seems like every time you turn around, there's a new source that's been found of some imported product. And here are some of the more recent sources of lead exposure that were identified, I believe, here in Maryland. So you can see the wide variety of toys and products that children might actually be exposed to in their play. Other sources of lead that we've seen here include coal and surma, cosmetics applied to the eye in certain cultures, medicinals, metal charms and jewelry, toys, candy from Mexico, lead in cigarettes we've spoken about already, and of course occupational exposures of parents, those doing construction, and environmental exposures in the do-it-yourself home repairs. Many young families buy older homes and then try to renovate them while they're pregnant with children, increasing the exposure of the pregnant woman and potentially children to lead dust and lead dust hazards. So how can we improve primary prevention? My thoughts, my recommendations on this, not described in the guidelines completely. But I think one thing we can do is we can use environmental assessment opportunities in the office to identify children at risk. We can use photos, drawings, to try to find out if children are exposed to known hazards. This cannot be really gathered by just an oral interview. So I think pictures are going to be really important in identifying, what kind of house do I live in? Do you live in a house that looks like this? Or you do live in a garden apartment that looks like this? Or do you live in a row house? Do you have peeling, chipping paint that looks something like this? So these kinds of things to really, because we're not in the home when child is in the office, how we can actually try to identify risky situations. It would also be possible here in Maryland to directly access age of housing data through the online tax registries or housing registries. And then, most important, assessment alone isn't going to do it. Connecting environmental office assessment findings with solutions. So the key here is the solution, and states and jurisdictions have different approaches. In Maryland, providers could assist a parent to prepare a notice of defect in cases where they learned in their assessment that the child was exposed to peeling, chipping, flaking paint, and they found out the house was built in, say, 1924. So this triggers action by the property owner based on their responsibility as established by Maryland law. And then it may trigger enforcement actions at the local or state level and should trigger action to take care of the hazard in rental housing. Now, providers are going to need to know if the child lives in rental housing or owner-occupied housing here in Maryland, because our laws vary in terms of what our requirements are. So in privately owned housing, there are many risks as well, particularly the renovation, remodeling, and painting, and poor maintenance for owners that are very low income and do not have the money to regularly maintain their homes. So clinicians are going to need to know who can follow through on these identified problems and how to contact them, just like we would any other referral. It's not a mystery, it's not rocket science. I think, again, connecting the office assessment with solution, there are potentially risky consumer products used particularly in key ethnic groups. This is a little girl has surma or coal applied around her eyes. This is a Reebok charm that actually fatally poisoned a child several years ago, and lead in jewelry is a real problem, and the city of Baltimore has been very proactive in testing jewelry and getting stuff removed from the market, but something we have to be continually observant about. And having laws in place and enforcing the laws are really important strategies that states are pursuing. I think we can also encourage parents to address smoking. And I would say that we've been very successful in convincing many at-risk pregnant mothers their unborn child would be at risk if they smoked during pregnancy. And I see evidence that many mothers, high-risk mothers, have stopped smoking 3 or 4 times during the 3 or 4 pregnancies they had. But our message is not that they should keep smoking cessation in place because smoking is harmful to their young child. That message has not been told, and we need to do some work in that area. And I think it's certainly an area that can be addressed by clinicians. Blood lead tests. Now, I would say that blood lead testing is only a small part of the recommendations. It's something providers do. They've done it for a year. It's part of established healthcare protocols, but it doesn't change exposures. And on its own, it's unlikely to result in changes in population health. Unfortunately, we're not really doing a great job of blood lead testing. Nationally, based on the NHANES data from 1999 to 2004, only 41.9% of Medicaid-enrolled children aged 1 to 5 had ever received any blood lead tests prior to their NHANES exam. This is during a period when it was required that all Medicaid children be screened with a blood lead test. Now in Maryland, between 2005 and 2010, we have screened 55% of Medicaid children, and in Baltimore City, 62%. So better than some of the national average, but I would say that's not good enough. And DHMH's target for screening is 80%. So we really need to beef up our approach to screening and not feel that we can make exceptions for certain parents or certain children based on what we think we know about their status and their exposures. In addition, there are laboratory implications, which I'll discuss shortly. Selection of the proper tubes are going to be very critical in terms of getting accurate measurements of lead. The follow-up testing guidelines are in the guidance, confirmation of a blood lead 5 to 9 within 1 to 3 months, and follow-up testing every 3 months until blood leads start to decline, and then every 6 to 9 months. So you can read those suggestions in the guidance. I'm not going to go into them right now. On the blood lead laboratory situation, I don't know how many states are in the same situation we're in Maryland, where our capacity really in terms of state laboratory capacity is restricted to oversight. We used to have a CDC reference lab. We do not have a lab doing blood leads here in this, at the state anymore. So we are restricted to being able to oversee the laboratories that are doing analysis on children in Maryland. So our surveillance requires reporting laws, an active program to ensure quality and follow-up. The accuracy is really affected by the equipment used in the analysis, the type of machines, and the supplies used in the blood draw. And there may be need to consider different methods of quality control, like submitting spike samples into the blood lead sampling stream, as we do now with environmental sampling. So as the blood leads have dropped over time, the analytic methods for blood lead testing have changed. And you see we've gone from Flame AA, ASV, to Delft's Cup, to Graphite Furnace, to ICP Mass Spec. And these are the little handheld machines, the lead care machines that are currently in use. Now, there are issues related to these methods. And I've highlighted the ASV method with using the large laboratory equipment and the 2 handheld pieces of equipment, because the limit of detection for these methods is higher than the limit of detection for both either graphite furnace or ICP mass spec. The costs are much lower, and they are also not automated. So we have some issues in blood lead measurement. If we're really interested in getting below 5, we are not going to be able to use some of these ASV methods. Now, in Maryland, MDE has looked at where we are with the laboratory reporting for 2011. And as you can see, 80% of the reports to MDE came from labs that used graphite furnace, 12.7 ICP mass spec, and only 7% or so in the ASV. So most of the blood leads coming in to Maryland, to our lead registry, were done on instruments that can detect these lower levels, which is really great. Sorry, there we go. So there's also a problem of contamination and error that's related to the sampling collection, the storage and transport, and the analysis. And at the higher blood lead levels, and this is a blood lead of 26.5 micrograms per deciliter, this average kind of error of this magnitude represents a 6% error in the blood lead. But when we go to a blood lead of 4.5 micrograms per deciliter, the same degree, the same magnitude of error is, in fact, 33% of the magnitude of the sample concentration. So that's a concern in terms of if we get to lower and lower levels, how accurate are the findings? So we also have some problems with specimen collection, and it has to do with what's called for. Often in pediatrics, we do a variety of tests together. And then these are the tubes recommended for these tests. However, the requirements for blood lead require the royal blue top EDTA or tan top lead-free tubes. So we're going to really need to look at the equipment being used for these multiple test situations to make sure that the tubes in which we have blood for blood lead analysis are in fact going to yield accurate results. In terms of healthcare reform, I think there's some opportunities here to use existing programs to assess for lead safety. We have really highly increased funding for evidence-based home visiting programs to parents and young children. Outcomes of interest include the outcomes impacted by lead. Where children live in older housing, somebody is going to have to address lead. The advantage is we already have people in the home. They could identify at-risk conditions, and they could connect families with solutions, as they do with other problems that they identify. So I think this is an opportunity that could be looked at the state level in terms of making this a requirement, especially in areas where there are a lot of children living in older houses. The medical homes and federally qualified health centers in high-risk areas could also use home visitors to assess for lead safety in the home environment. There has been much discussion and quite a bit of evidence to show that it makes sense to send home visitors into the home for children with asthma. This could be, and it's being evaluated for other issues as well with regards to young children. This could certainly be done for children with either at-risk home environments based on the environmental assessment or with a higher blood lead level. We can also use care managers in the clinic setting to coordinate the assessment and follow-up. And that's certainly a role for nurses that I think is very feasible. So state and local health departments have been facing a number of challenges, particularly lack of resources. And I think there's really a need to identify resources for public health. There have been state and local budget cuts in the past in Maryland where we had somebody who was at least half-time available for lead follow-up. Now we have no one available. So it's really important that we consider how we're funding our state and local infrastructure if we expect people at the state and local level to do follow-up of any kind or coordinate care. Again, I mentioned already the drop in funding, which is very significant. I think there will also be the need to monitor individual and population lead levels. And we should be thinking about population. Prevalence of blood leads of 5 and above are not equally distributed in the US population. The NHANES data, that's the result of NHANES population survey. But in Maryland, for example, based on 2010 data, we have 0.5% of children greater than or equal to 10 and 3.6% greater than or equal to 5. So we're already higher than the NHANES would suggest. However, there are places that even have a bigger problem. And in my study in Providence of kindergarten students, and these were kindergartners between 2004 and 2006, we had access to all their blood lead levels. 20% of the children in kindergarten during those years had had at least one blood lead level greater than or equal to 10. 67% had had at least one blood level greater than or equal to 5. That's the majority of children. I would suggest that since we don't really look at populations this way, like who's in our public schools and what was their history of lead, we really don't have as good an idea or an understanding of the kind of exposures that are facing public schools and children in public schools. The history of exposure is really quite extraordinary. Another way of thinking about this is that only 31% of Providence kindergarten children had all blood leads under 5 microgram per deciliter, compared to, I think, the expectation of 93% for the NHANES population of 1999 to 2004. So really considerably different problems in urban areas with older housing and other areas with older housing as well. So focusing on using the tools we have to identify hazards in housing before children are poisoned. I mean, I think this could involve visual assessment and dust testing in neighborhoods that are identified at risk, followed by targeted efforts to enforce housing code and to provide assistance where needed. The real idea, I think, here is to look at populations, not secondary follow-up of individual children identified in a doctor's office. So really to change our focus and our direction. So there are many different ways, different things that can be done. I think where the majority of children are exposed, for instance, like in the Providence example, it would be wise to consider something like universal access to preschool education. We know there are effects of lead on school outcomes. We know preschool education makes a huge difference in terms of children being ready to learn and then succeed in school. We need to do many things at many levels to try to ensure that our kids have a healthier future and a brighter future. At state and local health departments, definitely lots of opportunities to expand data linkages, linking blood lead with educational data, using electronic medical records to track screenings and health outcomes, having databases that are where the registry data is accessible to private providers so they can look up to see children's blood leads, and this is part of the infrastructure in Rhode Island. And then certainly assessing the analytic capacity for blood lead laboratories, as we discussed. There are other issues that will be taken up by other federal partners. The dust and soil standards currently in place are not health-based standards, and those are being looked at, I understand. And certainly to focus more on prevention, we're going to need to address those. There's going to be a continued need to emphasize prevention in the activities that generate lead dust. Renovation, repair, and painting. Funding for lead hazard control in many different ways is going to be important, and I think early education is a part of the solution, and we certainly need the Department of Education involved in the discussion. What I see as barriers, I think the funding is one of the biggest barriers. If there were program layoffs in some of these programs, it would severely impact capacity. We have long-standing programs with long histories. It's a complex subject, takes about a year for someone to really get their arms around this issue. And if we have layoffs of key people, it would be very difficult to put the infrastructure back into place. Then I think the current capacity of public health system really needs to be addressed in a holistic way to make sure we have the capacity going forward to address the public health needs of our populations. On the opportunity side, I think we have evidence and policy that supports primary prevention as a priority. We have studies that show that addressing lead in the environment is cost effective. We have a national program with state and local affiliates of more than 20 years of experience and more than 22 years, I believe, of funding, at the categorical funding of these state and local programs, including Maryland. That's a huge, huge asset. And healthcare reform includes some new approaches and may increase assessment options that we have in the home going forward. So that's it for me. Oh, I'm sorry, next steps, I think, funding. Definitely, I think people need to be involved and ensure that we get additional funding for these programs, that people care about it. People need to hear from you on the Hill. Additional guidance may be needed from CDC. No size is going to fit all, but I think the state and local health departments have sufficient information to begin to develop plans. They won't be here overnight, but they're working on them now, and it's something that you can expect from them in the future. In terms of population health, the focus will be on housing and other known exposure sources, and I expect we'll see a lot more collaboration with the provider community as we figure out ways to focus on primary prevention, provide information to families, empower families to take action, and increase coordination in ways that really are meaningful in this area. So with that, I'm done, and I think we're open to questions and comments.
So I want to thank both Dr. Navas-Acien and Dr. McLean and invite them both up to the podium. Thank you very much, both of you. Come on up.